In this part of the video, we will start to see about drilling strategies. There are, in fact, some small tips and tricks with whom we can improve and adapt to the clinical situation our work with the vertical approach. Let's see these things in details. Okay. The first concept is that with the vertical preparation, the main mistake that I see is to see conical abutments. It's very easy to make conical abutments. So the first thing that we have to assess is to visualize in a very clear way the natural axis of the neighboring tooth. Okay, we have to follow the natural axis. We have always to remember that the taper of the abutments is of paramount importance for the retention, the stability, and to avoid the cementation, the risk of decay a long time. So, look here, the first yellow line is the natural axis of the first bicuspid, and look again, the axis of the bar when we go straight again with our bar is almost the same. The butt bar is not perfectly cylindrical, there is a slight conicity. So doing this kind of works automatically, thanks to the shape of the bar, we'll obtain a tapering of 2 degrees on the wall of this tooth. And 2 degrees plus 2 degrees, we will have a conicity, a tapering of 4 degrees, okay? In most of the cases, of course, we will do slightly more because we are not a CAD-CAM machine. We are not at all something like this. But it's important to remember that we have to try to be as vertical as possible without leaving undercuts, of course, under our preparation in order to obtain this kind of preparation. We'll see that excessive tapering is one of the main mistakes and one of the main causes, especially with zirconia crowns that are already more loose at the introduce of the restoration. And after we go on the tooth surface, okay, but always keeping the same axis. We will see at the end of this video, we'll see also how to give more space to vertical preparation. Because there is a sort of wrong rationality that it is driven by the horizontal rationality that you start to do, you would like to go inside the tooth with your bar, but with the vertical approach, the approach is completely different, and we will see this in detail together with the management of emergence profile. Okay, with the butt bar, I want to highlight that we can do the so-called minimal invasiveness prosthetic dentistry if we use our butt bar without going over the cement enamel junction. Because of the inner anatomy of our teeth, when we do this kind of preparation without going over the cement enamel junction, we are able to preserve all the dentinal core and a part of the enamel. Okay, this is what we do. This is the minimal invasive protocol. When we do more, we are not forced like in the classic protocol, we have to drill everything more. But in our protocol, we are talking about the flexibility of this kind of protocol. We can give more space exactly where we want. So we can do what they call selective drilling or selective enamel and dentin drilling. For example, let's think about an anterior abutment, okay? On an anterior abutment, for example, let's try to think about this. On the buccal surface, maybe we can need more space for aesthetic reason, to improve the soft tissue. I showed you some cases of recession on anterior cases. You can need more space for your technician. But on the palatal wall, instead, you have no aesthetic issues. You have no problems about soft tissue, about covering the abutment. And we know also, look at the videos about biomechanics with Pasquale, we know also that the palatal wall is of paramount importance for the biomechanical strength of the tooth. So on an anterior tooth, my usual approach is, for example, to do a minimal invasive approach interproximally and on the palatal wall, especially in the area of the cingulum, and instead we can prepare a little more in the buccal area. We can go slightly deeper on the buccal area in order to improve the thickness of the soft tissue and in order to obtain some more space for our technician. Okay? Doing this, going deeper also with our bar, we will end up with a longer abutment. Okay? So, if we keep the same axis, we will have the taper is always the same, so the conicity of the abutment, but the retention will be a bit more because we are working with the longer abutment. We will have more space in this area, like for example with the example of the anterior incisors on the buccal area, and we can do soft tissue modifications of tissue, like in the BOPT technique they show in many cases. I do this approach often in anterior cases. I show you. This was a really compromised case of an anterior lateral incisors. This was almost completely composite restoration of ringing and with some endodontic problems. I did the new endodontic treatment. This is the new preparation. On the buccal surface, I've been slightly more invasive in order to get more space. And this is the final crown. So what I did, I give more space and I improve soft tissue, paying a biomechanical, a biological, we can say, price on that wall, but we have 4 walls, buccal, palatal, mesial and distal. But on the other 3 walls, instead I do a minimal invasive approach, keeping all the thickness in order to mix the needs of the aesthetic of the buccal area with the needs of strength of the other walls. Okay? In this case, for example, if you remember this case, the patient was scared because of the previous dentist about the risk of recession on this tooth, and there was also a dark abutment and there was some transparency. You see here some darkening of the gingiva. So in this case, I was in need of improvement of this area. So this is the reason, because I did a very deep preparation in this area. I did the management of the provisional. We will see more about the management of the provisional, how we do them, how we align them. Okay, this is the provisional. This is the provisional after the healing of the soft tissue, the day of the impression. Look here the improvement that we have on the soft tissue. And here is the recall of this patient after some years. Okay, look the improvement that we have on soft tissue. In this case, I have drilled a lot this tooth. I am paying a biological price for sure, but I'm doing this because I have a reason. And the reason in this case is to have more space, because the color of this patient was not easy for my technician, and he asked me some more space in order to obtain a good aesthetic on this ceramic, and in order to obtain an improvement and the stabilization of soft tissue. So, if I need something, I pay something. But if I don't need something, I don't pay the price. This is the difference of the tomorrow tooth approach with other vertical approaches. Let's see another kind of situation. When I deal, especially in posterior area, with some molar, for example, with short abutments, and I have the problem of retention, another strategy that we can use to improve retention is to reduce the taper just a little bit and to go deeper in the soft tissue. In doing this, we have a slightly longer abutment and the reduction of the taper. Doing this helps a lot the retention of the future crown. I do this in many cases when I deal with old endodontic treatment, where I am forced to do again the endodontic treatment for endodontic problems, and I have to deal, because of some extrusion, crowns with very short abutments. I show you this other case. This is a case of some old endodontic treatments. There were a problem of broken instruments on the mesial of the lower second molar. there was a short treatment of the mesial root of first molar. There was a short treatment also on the distal, but on the CBCT exam I did before redoing these endodontic treatments, there was no lesion, no kind of apical lesion on this root. So I have been able to bypass the mesial broken instruments on the second molar. I have been able to arrive to the apex of the mesial of the first molar, and I have not been able to find patency to the apex on the distal, but as I told you, in that area there was no lesion. So this is the endodontic part, but look here how the degree of compromission of this kind of teeth. So what I do in this case, I am dealing with very short abutments. I help myself doing this sort of boxes, more on this in other videos. This is the impression that I've been able to obtain thanks to the use of the butt bar. But this is the image that I want to highlight. Look how short is the abutment. You recognize this perfectly when you look at the lingual wall. But look the height of the lingual wall that you have in this slide. And look here, working just slightly deeply in the sulcus and using the smooth part of the bar to open the gingiva. Look here on the right, here. Look how much wall I have been able to recover that was hidden subgingivally and that I can use in order to increase the retention of my crown, because in this way I'm working on a longer abutment. Look here, this is the lingual wall of the second molar in the cast. It was something less than 2 millimeters in the mouth, but in the model I am close to 3 millimeters. I have been able to use all the wall that was in the sulcus, 1 millimeter full, in order to improve from 2 millimeters to 3 millimeters is 50% more of height of the wall. And we have much more retention in this case. And these are the finished crowns, always in zirconia, monolithic zirconia, after the delivery in the mouth of this patient. An interesting topic is how to prepare more on vertical preparation, because I already highlighted that when we do the minimally invasive protocol and I stop on the cement enamel junction, I have this sort of tooth reduction. I am able to preserve all the dentin core and some enamel, but doing this, obviously, I have a very thin prosthetic space. We will go deeper on this on other videos. But if I want, because I am forced to use, for example, a porcelain fused to metal, and for using porcelain fused to metal PFM crowns on vertical preparations, I need more space, definitely. Or if for any reason I need more space, how do we obtain more space on vertical preparation? What I see in many cases is that people tend to tilt the bar. In this way, it's true that you obtain more space, but you end with two conical abutments. And in this way, you will risk decementation and decay. So more prosthetic space, but loss of resistance form and risk of decementation. Instead, this is related to the fact that we, at the beginning, for new bio vertical preparation, we tend to think to vertical preparation in the same way of horizontal, that we have to go deeper with the bar inside the tooth. Instead, with vertical preparation, the concept is completely different. If we want to have more space with vertical preparation, we have to keep the same axis of the bar, and we have to go in this way. We have to go, keeping the same axis, we have to go deeper inside the sulcus, okay? Deeper inside the sulcus. In this way, we do something like this. The axis is always the same, but because the tooth in the root has a natural conicity, drilling and the narrow part of the abutment, we will end up with much more prosthetic space. So we have not to change the bar, the angulation of the bar, but we have to move in this way. We have to move towards the tooth, but deeper in the sulcus. Okay? Doing this, we will be able, like people in the original protocol do, we will be able to attain a lot of space, because we can drill even starting from the bone if we want. Now I want to explain something about the emergence profile, because let's think that this is our tooth and our gingiva. Follow me, try to follow me. This in red is the profile of the tooth. If we do a minimally invasive approach, the blue line, we have an edge and we can start our crown. You see that if we fill the space between the blue line and the red line, we have the new profile of the crown. And the emergence profile of the crown is a very normal, we can say, emergence profile. Okay? Instead, when we do a very deep preparation, we have to deal with a completely different emergence profile that I want to highlight. Let's think that we are working with a very deep preparation close to the bone crest. We have the sort of mold chamfer close to the bone crest. Okay? Now we have a huge difference between these two lines, between the red line and the blue line. But we are not able to start with our crown from the apical point of preparation, because we have to stay always in the space after the healing of soft tissue. We can go 1 millimeter, no more, 1 millimeter 0.5 in some cases, inside the sulcus. So when we do this concept that it is very typical of the BOPT technique, we will do a very convex emergence profile, because we have to match with this emergence profile the distance between the tooth after the preparation and the future profile. It's like that you have to connect these two different surfaces. And this is the reason because in the BOPT protocol, they are working with this so convex emergence profile. This is not a choice. If you do that kind of tooth reduction, you have no other solution, you have no other choices than doing this extreme convex profile. I have to say that in my experience, this sort of profile is perfectly accepted by soft tissue. The problem is always a biomechanical one, that you do a huge reduction on the tooth, especially in the area of the pericervical dentin. And if you mix this with the straight line endodontic access, you will end up with a very nice crown, that it is very friendly about soft tissue, but with a very weak tooth that will be very prone to an horizontal fracture after some years. Okay? So it's not about deciding which emergence profile you will give to your restoration, but it's a need. If you do a minimal preparation, you will start with a normal emergence profile. But if you do a very deep preparation and you have a huge distance between the future emergence profile of the crown and the surface of the tooth, you will start with a very convex emergence profile. This can be helpful because when you work, for example, with porcelain fused to metal, having this sort of emergence, like you see, for example, in these crowns made by the technician of Ignazio Loi, the metal collar will be completely hidden to the view, because if you have a metal collar, but with a normal emergence profile, this is the visibility of the metal collar. If the metal collar, instead of being flat with the normal emergence profile, let's think is in this way, you have a reduced visibility of this metal collar that, together with the increased thickness of the soft tissue created by the tooth reduction, make this metal collar almost invisible. So when you work, for example, with PFM, to do because you need more space and you need to hide the metal collar, if you do this kind of reduction and you work with this kind of emergence profile, is very, very helpful. But it's important, like I highlighted in other cases, that you do this because you need something. You need more space because you are working with PFM, because you need to hide the metal color. Okay, you prepare more the tooth, you have much more prosthetic space, you have better gingiva, you are paying a biological price on the tooth in order to obtain some advantages. But what is important for me is always to have this concept clear in your mind. You can pay a biological price when you need something, not without a purpose. Okay? This is everything for this video. See you in the other videos of this video course. Bye guys.